Thromboangiitis obliterans. It is somewhat rare non-atherosclerotic segmental recurrent inflammatory vaso-occlusive disorder of the small and medium-sized arteries, veins, and nerves of the upper and lower extremities. On very rare occasions, systematic manifestations of the disease may involve cerebral, mesenteric, and coronary arteries. The disorder occurs predominantly in younger men, exactly below 40 years of age. However, as many as 40% of patients with this disease are women. Buerger's disease is a type of arthritis in which an inflammatory process damages the arterial wall. Lymphocytes and giant cells infiltrate the vessel wall, accompanied by fibroblast proliferation. Ultimately, thrombosis and fibrosis occur inside the wall, causing tissue ischemia. Buerger's disease typically being with ischemia of the small distal arteries and veins, progressing to more proximal arteries. There is a very strong relationship between Buerger's disease and tobacco use. The symptoms complex of Buerger's disease is often confused with peripheral artery disease and a variety of other inflammatory or autoimmune diseases. Patient may have intermittent claudications of the feet, hands, or arms. As the disease progresses, pain and ischemic ulceration develop. Other signs and symptoms may include temperature changes in the affected limb or lymphs, paresthesia, superficial thrombophlebitis, and cold sensitivity. There is no laboratory or diagnostic test specific to Buerger's disease. Diagnosis is made based on age of onset, history of tobacco use, clinical symptoms, involvement of distal vessels, presence of ischemic ulceration, and exclusion of diabetic mellitus, autoimmune disease, thrombophilia, and proximal source of emboli. Recent research indicates that patients with Buerger's disease have altered hemorrhagic parameters. That means higher hematocrit, blood viscosity, and RBC level is rigidity. Compared to patients with a peripheral artery disease and healthy controls. This may have implications for the diagnosis and treatment of this disease. Treatments include complete cessation of tobacco use in any form. Nicotine replacement products should not be used. Trauma to the extremity must be avoided. Patients are told that they have a choice between their cigarettes and their affected limb. They cannot have both. Painful ulceration may necessitate finger or toe amputations. Amputation below the knee may be necessary in advanced cases. The amputation rare in the patient who continue tobacco use is 84.3% compared to only 30.6% in patients who discontinue tobacco use. The risk of amputation is eliminated by 8 years after discontinuing tobacco use. Patients with Buerger's disease have a significantly lower survival rate than age and gender matched controls. Although the amputation rate is lower in patients who stop using tobacco. Risk of death is similar in those who continue to use tobacco and those who quit. Other therapies can be considered but have had limited success. The most commonly used medicines are antiplatelet agents, followed by calcium channel blockers, alpha adrenergic blockers, and anticoagulants. Surgical opinions include revascularization and sympathectomy, with the most common being sympathectomy, that means transection of nerve ganglion, and, and or plexus of the sympathetic nerve system. While sympathectomy is useful in improving distal blood flow and healing of ulceration and reducing pain, it does not alter the inflammatory process associated with the Buerger's disease.